صباح الخير للجميع وإن شاء الله يعني we want to start on time although we are so far 5 minutes late because I think we have to strict to the time of 10 minutes for each free communication and our distinguished speakers will start at 9 o'clock exactly because we want to finish on time because we have prayers, we have ceremony and we have 15 lectures. The first presentation will be by Dr. Lujain Lataife. She will present her research, I think, misinterpretation of silver-coated wound dressing as oral contrast bowel leak case report. Please, Dr. Lujain.
Good morning, everyone. I would like to thank the scientific committee for giving me the chance to present my case report. Our case report highlights a diagnostic pitfall, which is silver wound dressing, masquerading as contrast extravasation. As a background, post-operative bowel leak is a serious complication. Post-op link can lead to high morbidity, mortality, and unnecessary surgical interventions. Our gold standard tool in diagnosing such cases is contrast-enhanced imaging. However, interpretation can be challenging sometimes because foreign materials such as mesh, hemostatic agents, dressing may mimic contrast extravasation. We started using silver-coated wound dressing for wound coverage due to their antimicrobial and wound healing benefits. What's special about silver that it can appear radio-dense on imaging. This characteristic is not widely recognized. So misinterpretation of the dressing material as bowel leak can lead to misdiagnosis and unnecessary tests, interventions, and sometimes reoperation. This is what happens in our case. Our patient was 51-year-old medically free patient. Her BMI was 41. She underwent total abdominal hysterectomy with bilateral salpingoophorectomy due to fibroid-related menorrhagia. Her surgery was uneventful. His recovery went smoothly. She was discharged on day 3 on oral antibiotics. The patient returns to the emergency department on day 9 with purulent discharge from the right wound angle. She had no symptoms suggestive of systemic infection. We sent her basic labs, CBC, CRP, they were unremarkable. Her wound was reopened to fascia due to excessive drainage from the wound. After consultation with the plastic team and wound care team, the plan was to keep it open and pack it with silver-coated dressing 3 times per day. 2 days after, we performed double contrast CT, and an opacity was noted along the transverse wound, which was reported as contrast extravasation, and this raises the suspicion for enterocutaneous fistula. As marked by the arrows, this is the transverse opacity that's noted on the wound. Multidisciplinary review between the gynecologist and radiologist was performed. Her clinical status was inconsistent with fistula, so this leads to suspected artifact. We repeated the CT without contrast after repacking with the silver dressing. The opacity persisted, which confirmed no leak. After confirming there were no leakage, it was managed with vacuum dressing and healing was achieved. Now, when we see such cases, we need to think about enterocutaneous fistula, intra-abdominal abscess, contrast extravasation, but what we should keep in mind is that it could be due to artifact from the silver-coated dressing or if we used any other radio-dense tools. Now, over-reliance on imaging without correlation with the clinical presentation puts us at increased risk for such misdiagnosis and unnecessary surgical interventions. In our case, our patient was clinically stable. There were no GI symptoms or systemic infection, which makes the true fistula unlikely. We always have to remember that we're evaluating the whole patient condition rather than considering the radiological or laboratory findings alone. Our lessons to take is that silver-coated dressing and iodine, they are radio-opaque. They can mimic the contrast leaks. Always, we need to consider dressing materials when interpreting CT findings. We need to consider removing the silver dressing before performing contrast-enhanced imaging. We can also use baseline non-contrast imaging to confirm whether it's an artifact or true leak. And finally, multidisciplinary communication is key to prevent such unnecessary interventions. Thank you.
Thank you, Dr. Lujain. Is there any question from the attendees? Dr. Abir? Microphone.
And just to counteract what's happening there for her leakage, but we didn't pay attention انه this could يعني give you this impression. فهاي النقطة أنا رأيي كتير مفيدة لإلنا كلياتنا، درس لإلنا إنه when you have it يعني think إنه this could you بعطيك يمكن منظر مش صحيح. ف remove it and then do the dressing and then do the X-ray. هلا there was a track but there was no symptoms of the patient. في كان track دكتور.
Thank you. The certain cuts, the transverse cut can't very similar or mimic in contrast leak. And again, even the surgical team, they were suspecting the fistula and they advised to go. Then I have to discuss with the senior radiologist there or the head of the department. And I explained to him, it's very important to give him clinical data, proper clinical data about the intra-op situation. Yeah, and to discuss it with them. Plus, زي ما حكى الدكتور عبير, the clinical situation was just nothing to suspect إنه فيش.
ممكن يكون إنه في small tract, very tiny, and it was healed by itself by granulation tissue أو ممكن صح؟
But see, again, anterior cutaneous fistula, maybe the presentation a bit earlier because عندك high volume من the content small bowel. This is number one, and it's very irritant. So you can notice this earlier on. She came back at day 9 or 10 without any clinical suspicion of the anterior cutaneous fistula. So the message here, just treat the patient as a whole, not just look at the imaging or the lab finding. So review the chart, again, evaluate her yourself without relying on the junior doctors, discuss it with the senior team personally, and come with the decision. And always, if there is no rush or no emergency, don't rush to surgery. Try to treat conservatively.
Okay, thank you. I think...
Yes.
Okay, thank you very much, Dr. Lujain.
Thank you, Dr. Lujain.
May I ask the next speaker, Dr. Al-Anud Al-Bustanji? Dr. Anud? Dr. Anud is chief resident, I think, at the specialty hospital. She will talk about uncommon cause of periurethral mass, periurethral leiomyoma. Please, Doctor.
Good morning. Thank you for the invitation. Today I will present to you an uncommon cause of periurethral mass, paraurethral leiomyoma. This case presentation supervised by the consultant Dr. Ayman Qatawne at the specialty hospital. First, we will talk about the patient presentation, physical examination, diagnostic imaging findings, surgical management, procedural details, post-operative outcome, and discussion with a brief literature review. Our patient is a 43 years old multiparous woman with unremarkable medical and surgical history. The patient presented with 1 month history of dyspareunia severe enough to adversely affect her sexual life, associated with lower urinary tract symptoms, sensation of incomplete voiding and intermittency, paraurethral bulge mass, and localized pain described as electrical impulses. By physical examination, abdominal and pelvic examination were unremarkable except for a palpable mass that found to be superior-lateral to the external urethral meatus with size of 1.2 by 2 centimeters. Firm in consistency, mobile with normal appearing skin coverage. Then diagnostic imaging showed transperineal ultrasound and MRI was done, and the findings was well-defined hypointense lesion, 2 by 1.7 centimeters in size, located anterior to the urethra on left anterolateral vulvar wall with no vaginal extension. These radiological findings were highly suggestive of paraurethral but primary urethral tumors could not be excluded. And as we see here, our patient's MRI images, as we can see in the picture at the left side, beside the urethra, we can see bladder, urethra, and our mass located inferiorly. And it's more clear on the image at the right side that our mass located, okay, thank you. So as we see here, we have the bladder, urethra, and this is our paraurethral mass. And at this picture, also it's clear to be seen that this is urethral meatus, and this is vagina, and this here located our mass, sized about 2 by 2 centimeters. Differential diagnoses for our mass were Bartholin gland cyst, skinny duct abscess, Gartner duct cyst, urethral carcinoma, urethral diverticulum, leiomyosarcoma, and metastatic lesions. Then detailed discussion for risks and benefits was conducted, informed decision made to proceed with surgical excision. Examination under anesthesia confirmed a 1.5 by 1.5 centimeters mass found to be mobile, superior, and left lateral to the external urethral meatus. Then surgical procedure was done. As a preparation, fully catheter inserted without any resistance, a longitudinal incision made over the mass, then well circumscribed lesion grasped and delivered by Alice forceps. Then hemostasis secured and dead space closed by layers. Now, here we have a real images for our procedure. As we can see, here, fully catheter inserted into the urethra without any resistance. This is our longitudinal incision over the mass. Then, well circumscribed mass excised by Alice forceps and dissection. Then, closure of the dead space was done. And this is our mass. As we can see, it looks firm, encapsulated. Then, post-operative outcome, immediate recovery was uneventful. Post-operative recovery, fully catheter removed on the first day post-op. The patient discharged 24 hours after the surgery with final histopathology report confirming paraurethral leiomyoma. 6 weeks follow-up that was, the patient was in excellent clinical and psychological health with complete resolution of symptoms and well-healed surgical site. Then histopathological results confirmed our diagnosis that finding was for benign spindle cell tumors with interlacing smooth muscle bundles, no atypia, necrosis, or mitosis. These all confirm paraurethral leiomyoma. And these are our patient's histopathology slides. Now, quick discussion about paraurethral leiomyoma. Leiomyomas are common benign tumors that can potentially arise in any organ containing smooth muscle cells. While uterine leiomyomas are frequently encountered, paraurethral leiomyomas are extremely rare and have been reported in both men and women. A true paraurethral leiomyoma is defined as mesenchymal neoplasm developing within the paraurethral space or vesicovaginal septum without any direct connection to vagina, urethra, or bladder. Distinguishing between vaginal, urethral, and paraurethral leiomyoma is often challenging due to their close anatomical relationship. In women, urethral leiomyoma originates from circular smooth muscles of the urethra, whereas paraurethral develops from surrounding smooth muscle structures. Clinically also, we can differentiate between them that the paraurethral leiomyoma tend to be mobile, whereas urethral are fixed and often visibly protrude through the urethral opening. Unlike urethral leiomyomas, paraurethral can typically be excised without any disruption of urethral muscle or mucosa. Now, a quick review of paraurethral leiomyoma case
Please
report.
stick to your time.
Yeah.
You have 1 minute.
This is last slide. Quick review of some case reports that reported between 2018 and 2025. As we can see, different age groups, different clinical presentations, different sizes, but at the end, it's same surgical management and successful outcome in most of them. This case demonstrates successful management of rare paraerythroleomyoma, highlighting importance of clinical suspicion, appropriate imaging, and surgical expertise in achieving optimal outcomes. Thank you.
Thank you very much. I think very interesting case. Dr. Ayman, did you leave a catheter after was excised? This
Yes.
mass?
For 1 day.
1 day. And what do you expect of like stricture or fistula in the urethra? Is it reported in cases like this? Urethral stricture or urethral fistula?
No, there was no extension from the mass to the urethra.
I know that you have no complication, but when you reviewed the cases, were these complications reported or not?
No, there was no complications like this because there is no direct connection between them. And surgical excision completely done.
So no entry to the urethral canal.
No.
It's removed from outside the urethral canal. Okay, thank you very much. Very nice case.
Yeah. Thank you.
I think Dr.
Next speaker will be Dr. Malik Al-Qasim. He is an assistant professor in fetal medicine at Mu'ta University. Dr. Malik, please.
Thank you. Thank you to giving opportunity to present my case. My case today, I'm speaking about role of statin in preeclampsia. So, do we need statin in some cases to prevent preeclampsia, and what are the benefit of statins in prevention of preeclampsia? So before start speaking about this, I have just a quick review about preeclampsia. We know that preeclampsia, according to the Fetal Medicine Foundation, it's a worldwide disease, and we have more than 50,000 women dying during each year due to preeclampsia and hypertension disorder during pregnancy. So the terminology of preeclampsia comes from 1903. It comes like hypertension, proteinuria plus eclampsia. So we call preeclampsia, and John Clarence Webster, he described this. So if we do a old review, it's a old disease. So we reported preeclampsia in Old Egyptian. So we found there is a womb and tremor on the wombs. It's called tremors of the womb. And we found this description very old. So this is an American journal, Obstetric and Gynecology, where I worked. I worked with the Professor Roberto Mario in this journal. So we have in our work in descriptions of etiology of preeclampsia, and we know preeclampsia not one type. We have so many types. Main types of preeclampsia, we have preterm preeclampsia and term preeclampsia. They are different in pathophysiology and management and outcome. So in our etiology, we describe in our work in National Institute of Health in Wayne State University in Detroit, at that time, we worked in this paper, so we found that so many etiology affected can cause preeclampsia. One of the most important, we know the etiology is like transformation of spiral artery and failure to transformation, one of the cause, but we found that there is also uteroplacental ischemia. So the preeclampsia is a syndrome, multiple causes, multiple pathology can cause preeclampsia, and we found there is not only a transformation, failure of transformation spiral artery, we found also there is a microthrombs in spiral artery. One of the main organ, one of the main pathology, there is also a microthrombs inside the spiral artery. And this mimics the acute MI. So we have a microthrombs inside the spiral artery, leading to decreased flow, leading to toxins, sulfonylurea tyrosinekinase, and decreased placental growth factor, may leading to preeclampsia. So the idea comes, why not to use statins in patients with history of preeclampsia or high risk preeclampsia? And we found that also This is the idea. This is a picture confirmed that there is an ischemia inside the placenta and placental infraction. We call this placental infraction leading to preeclampsia. So why not use pravastatin? So we chose the first generation statin, pravastatin. It's a most hydrophilic statin, and it's affecting by decreased cholesterol level. We start choice pravastatin in experiment firstly, then we used in a human. In the experiments, we found that statins affecting placental growth factor and affecting soluble flat tyrosine kinase, which is the toxin in preeclampsia. So we use it in multiple cases. In 2023, the meta-analysis come with a pravastatin in preeclampsia. It can prevent not only preeclampsia by itself, it can also prevent growth-restricted baby and prevent preterm labor, preterm birth, decrease in ICU admissions. We found so many papers. Pravastatin also in 2017 proved to not only prevention preeclampsia, it can also treat preeclampsia. So we can give also to treat preeclampsia. This is other paper describe how to use pravastatin in prevention preeclampsia in case with antiphospholipid syndrome. Also after that, so many papers come in 2023 describe pravastatin and aspirin together in prevent in high-risk patient of preeclampsia. So depend on that, I have a case. My case, she's a gravida 2 para 1. She presented to my clinic. In para 1, she delivered preterm cesarean section due to preterm severe preeclampsia, and the baby died due to prematurity. Patient have complicated cesarean with magnesium sulfate, admissions and follow-up. So, and this patient, she had DM type 1, never been controlled, always hemoglobin A1C variation between 8 and 13. So she came to my clinic asking about next step, how to get pregnancy. So I start counseling her about pravastatin. She was the first woman in Jordan receiving pravastatin and aspirin. I start aspirin and pravastatin after 12 weeks gestation and follow up every 2-3 weeks. Patient start very smoothly antenatal care. She came to my clinic at 31 weeks complaining of headache, blurred of vision. At that time, I increased the dose of statins to 80 milligram, and she improved after 2 days. So follow up here till 36 weeks. We stop statin, we stop aspirin, and she came at 37 weeks for cesarean section. We did cesarean section. She was very good status. She discharged home with her baby with very good status for the baby. So my notes here that I reported this case because we gave statin to prevent preeclampsia. And what I mentioned in my paper that I increased the dose. Increasing the dose sometimes improve the outcome, the first findings, and the amazing findings that DM type 1 status. So the patient, she had hemoglobin A1C 13 before pregnancy. At the end of pregnancy, it was 4.8, and this is the first time in her life that hemoglobin A1C dropped to 4, even with the same regimen of insulin. So I reported the case in International Journal of Obstetrics and Gynecology that the role of statin not only prevents preeclampsia, it may also control DM type 1. Thank you.
Thank you, Dr. Malik. We have time for 2 questions.
Thank you very much, Dr. Malik. Although it is only a case report, but it is usually categorized as X and contraindicated in pregnancy use, and by all the FIGO, RCOG, and the RCOG, it's contraindicated and still experimental. So we have just to make sure that this is not for everybody to use.
Yes.
So there are case reports. We are waiting for RCTs, but we can't apply it for everybody.
Yes, Dr. Amir, I think the randomized control trials comes out regarding pravastatin and other statins. So the pravastatin I use now in 15 patients. I'm collecting data now. So I select cases in my work in my university. We discuss the status with the women before start because the medication is not available in Jordan.
Yes.
So they bring the medication outside from Jordan.
And this is another thing. So you don't have the Jordan FDA approval of the drug use. So
We
this
have
is-
other statins.
I know, but I
Not
know,
pravastatin.
but these are, all of them are contraindicated.
Yes.
This is the only one which can be used, and it's been used, and there are 500 reported cases, and it is not safe to be used in breastfeeding as well. So we have to be careful.
Yes, yes.
We
do-
agree that we are following, a
Guidelines,
new
new guidelines.
RCD as a new guidelines,
But
so not everybody will be going to use it.
Yes, sure.
Yeah.
But in Fetal Medicine Foundation website, they approved now as a prevention preeclampsia. So they approved, and we have
Yes.
randomized. But
Yeah.
in Jordan, we still work on.
And you have the baby aspirin. You can start at 12 weeks by 150 milligram, and you can do also the risk reduction by doing the first trimester, accuracy for it, which he have
stat,
PET
yes.
or not. So but you have the baby aspirin and it's been
Not all patients improved on aspirin. It can prevent by 80% just preeclampsia. It's good, but we can also for high-risk patient, obese patient. I select my
Well,
cases
Abir.
now.
Yeah.
Thank you.
So, yes.
Yeah, I know. But this
Yes.
is a message for everybody.
Yes, message, yes.
So, yeah,
It's just under
just
research.
be careful. Yeah, thank you.
Thank you.
Thank you very much, Doctor. Is Dr. Hassan here? Dr. Muhammad Hassan, is he around? I thank all the junior doctors for their nice presentations. We always like to encourage them while they are residents, so by the time they finish their residency and become consultants or specialists, they will have the experience and maybe it will help them in the future when and it helps their CV as well if they want to apply for academic jobs. I don't know what is happening. We have 3 minutes waiting for Dr. Hassan. He's not here, but if he is not arriving on time, I think we will start with the following speaker. Professor Rani Thacker will start instead of him. Abir, can you call Hassan? Because he's supposed to be. And may I ask Professor Rani Thacker, is she around? Professor Rani, I think Dr. Hassan, I don't know what is happening, why he's late. Is your slides ready? So may I call Professor Rani Thacker? Professor Rani Thacker will talk to us about unraveling the effects of childbirth on pelvic floor. Professor Rani Thacker is the president of the Royal College of Obstetricians and Gynecologists since December 2022. She is a consultant obstetrician and gynecologist and urogynecologist at Croydon University Hospital, honorary senior lecturer at St. George's University of London, and honorary president of Women Health at University of Liverpool. In recognition of her leadership, she was awarded the President's Award for Outstanding Leadership by the British Association of Physicians of Indian origin in 2023. Professor Rani Thacker is well known to us, and this is her, I believe, your third visit to Jordan. You are welcome, and we hope to see you in the future. Please, Professor Thacker.
Thank you. Thank you so much for that kind introduction. It's really a pleasure to come back to Jordan. I always feel very much at home. Your hospitality, your affection feels very much like it is when I go to India. So I'd like to really thank you. This is my last visit here as president. I hope I will be visiting afterwards. But it's really been a pleasure to associate with you and our IRC committee, who have been absolutely amazing in really promoting women's health in Jordan. So I'm going to talk about a subject that's I'm really, really passionate about. Now, pelvic floor dysfunction, be it urinary or anal incontinence or prolapse, is very common. So if you look at statistics, we know that 1 in 4 women will suffer from pelvic floor dysfunction during their lifetime. This can be incontinence, it can be prolapse, it can be sexual dysfunction. 20% will have surgery, and there are many more who have conservative management who are not even counted. So it's an area that really is under-resourced, under-researched, and underfunded. No, I'm fine. But really what I'm going to talk about is why does this happen? One of the main causes is childbirth, and it's really not a surprise if you think about the damage that happens to the pelvic floor during a vaginal birth. So over the next 20 minutes or so, I'm going to cover various aspects so that I fully cover this topic and make you understand the importance of the pelvic floor and why each one of you needs to be an advocate for women with pelvic floor dysfunction. So I'm going to start off by trying to understand what is the pelvic floor and why does childbirth in humans be so difficult? Why is it so vulnerable to injury? And then we'll talk about the consequences of this injury. But not everybody is at risk. So who are these women who are at risk so that we can look at that and we can try and prevent this injury so women do not have a poor quality of life. Because I'll tell you what, I see these women in my clinic every single day and their quality of life is really poor. And last but not least, we'll talk about how can we address this? Can we do anything with training? So this is the pelvic floor. It's the main muscle that occupies the outlet of the pelvis. All your pelvic organs are sitting on this fantastic muscle, which is made up of muscle, connective tissue, ligaments. And if you look at it over here, you will see that the fibers in it are crisscrossed. This muscle has got tone. It keeps your pelvic organs in position, and that's why continence is maintained. That's why the pelvic organs are kept within the body. And really, it's been a muscle that has confused anatomists for a long time. Anatomists haven't understood why the body of this muscle, they do not understand the function of this muscle, and we still do not understand it. Our understanding of this muscle has increased after we started doing imaging of the pelvic floor, but there is a lot more that we need to understand about the levator ani muscle, or the main muscle of the pelvic floor. So the next question is, what makes childbirth so difficult in humans? Let's think about the evolution. We started off as four-legged animals, okay? That was 5 to 7 million years ago. And we gradually evolved to become bipedalic, that is walking on two legs as I'm standing here today. What that meant is there needed to be a remodeling of the pelvic floor. To hold your pelvic organs in, the bones had to change, the muscle had to change as the human became upright. This started about 7 million years ago, as you can see in the graph over here. And then in the last 2 million years, the brain of the human grew in size, and you can see over here that the brain now became bigger than the pelvis, because as the evolution took place, the pelvis became smaller, the brain became bigger, the fetus's body became bigger, and that really caused an obstetric dilemma. That is what causes the pelvic floor muscles to be damaged during childbirth. As that fetus makes that most hazardous journey in its lifetime through the levator hiatus, stretching it. What is the consequence? As the pelvic floor gets stretched along with the nerves is childbirth trauma. And this can be nerve damage, where we call pudendal neuropathy, or it can be direct mechanical trauma to the fascia, to the ligaments, to the muscle. And that is what leads to pelvic floor dysfunction. So let's look at what happens to the levator ani muscle. If you look at the perineum during childbirth in the second stage, you won't realize what is happening underneath. But as that head is coming out through that levator hiatus, you can see over here in the picture that those muscles stretch. that nerve stretches as that head is coming out through that narrow hiatus, stretching it. Because this nerve, the pudendal nerve, is fixed. When we say that childbirth injury leads to nerve damage, it isn't that it is cut, it is stretched. And that's called pudendal neuropathy. How do we know this? Well, there have been lots of studies done, and this is a computerized image from Professor Delancey's unit. So that blue sphere, imagine, is a fetal head. You can see the early second stage and the late second stage. So try and imagine that fetal head coming out through that levator hiatus. Now, muscle is like a rubber band, okay? So when you stretch it, it will stretch to a certain extent. When it reaches its maximum stretch, it breaks. That's exactly what happens to the levator ani muscle. Those medial fibers that are attached into the pubic bone, they stretch, and they cannot stretch anymore, and that leads to damage to the levator ani muscle. Now, there are two types of damage over here. There can be enlargement of the levator hiatus, or there can be detachment or levator avulsion. So the muscle gets detached. Can I have a pointer, please? So you can see over here that the muscle gets detached. This is an MRI image showing you the urethra over here and the anal canal, and you can see that the, where is it? This one? Oops. Sorry. So you can see over here that it is not working. Yeah, so you can see where the black arrow is where it is attached, and where the white arrow is, it is detached. Now, if you're careful and you look at the perineum when you do your examination, you will be able to tell that whether a woman has got an attachment or detachment. So I've labeled this normal, and you can see that there is no detachment over here. But then if you look at the abnormal image, you will see that detachment has taken place, so the levator hiatus has increased, and the shape has changed, okay? So you can see there's enlargement, there's ballooning. And this occurs in about 4 to 16% of women. Different studies have looked at this, and we know that levator enlargement occurs, and this is the biggest precursor for prolapse later on in life. On the right-hand side over here, you will see an MRI image showing you where the black arrow is attached and detached. And then if you look at that perineum, you can see exactly where the attachment is, where the black arrow is, and the detachment, where the white arrow is. So get used to examining the pelvic floor, and you will actually be able to see with your naked eye whether there's an attachment or detachment. And we have shown this in studies wherein we evaluated women antenatally, in the postnatal period, in the short term and the long term. And I wish this was working, but it isn't working very well. But you can see over here where the white arrows is the detachment. And we use the GE machine, and you can see the slices over here. That's where the detachment is. And this occurs in about 21% of births. Now let's try and imagine why one would get prolapse due to this. In image A, you will see a normal uterus, vagina, and the pressures on the vagina when your levator muscle is not damaged are equal. But when enlargement takes place or this detachment takes place, the pressures on the vagina are unequal. And therefore, you have a drop in the uterus and also the bladder. Okay? So that's what happens. I'll just show it to you as I get my pointer here. You can see over here that there's a pull on the uterus because this is unable to keep everything up. I told you this muscle has got tone. And then you can see that the bladder and uterus starts dropping. Okay? This is because of injury to the levator muscle. That enlargement, that detachment. And this is what predisposes women to prolapse. Now let's look at what happens during urinary incontinence. Why do women get urinary incontinence? Here you will see the urethra sitting nicely on the fascia, on top of the vagina. But when fascial damage takes place, it's almost that our hammock really gets detached, and therefore, when there's increase in intra-abdominal pressure, instead of getting squashed, it actually opens up. And therefore, when women cough or sneeze, when there's increased intra-abdominal pressure, they get urinary incontinence. So urinary incontinence after childbirth is due to fascial damage, it can be nerve damage, or it can be muscle damage. And we have shown this by doing studies on the pelvic floor using ultrasound, antenatally and postnatally. We know that after vaginal birth, there is increase in bladder, neck, and urethral mobility. It is more in presence of levator ani muscle, and this correlates directly to stress urinary incontinence. What about anal incontinence? Ladies and gentlemen, obstetric anal sphincter injury is the most common cause for anal incontinence, which has to be the worst symptom that can affect a woman. This occurs during childbirth. When the fetus is coming out, when that perineal body actually stretches and the tear extends into the anal canal. But when women get anal incontinence after childbirth, it's due to mechanical injury, but also nerve injury. And this can occur in about 3% of women who give birth vaginally, and more common to occur in primates. But there's something else that also occurs after childbirth, and that's sexual dysfunction. And the causation for this is multifactorial. It can be physical, it can be psychological, it can be the change in life, it can be due to breastfeeding. And these are things that we need to take into consideration when we are looking at women who have pelvic floor dysfunction after childbirth, because the causation is multifactorial. I mean, mustn't be afraid to ask women if they have sexual problems after childbirth, because many do, we just do not ask them. So to summarize that aspect, the consequences of pelvic floor trauma are many. You can get incontinence, be it urinary or anal incontinence. There can be prolapse or sexual dysfunction. But we also know from studies that as a woman grows older, with lapse of time, there is increase in anal and urinary incontinence. And the only way to prevent this is to have an exclusive cesarean section, and we'll come back to that. It's also more likely to occur in women who have prolapse, and we know that one of the risk factors is high BMI. What about prolapse? Well, in a study that we did, we found that prolapse, objective prolapse on examination increases 5 years after vaginal birth, not after cesarean section. But really the symptoms get worse with time. But there is one risk factor again, and that is increased BMI. So we know from studies that symptomatic pelvic organ prolapse increased by 3% for each unit increase in current BMI. And also it is correlated to the infant bed. But then you'll say to me, well, should everybody have cesarean sections? Well, it may be a woman's choice. But when we are counseling women, we need to tell them about the immediate effects, the immediate risks, the delayed risks, and the risks later on in life. And let's think about that. But how do we prevent this? Well, for that, we need to take into consideration the risk factors. And the risk factors for this are many. But the main thing is age, and you cannot modify that. But obesity is a common risk factor for urinary anal incontinence and also prolapse. And that is something we can do something about. But let's assume that all women, when they are born, have a normal pelvic floor and we do not get prolapse. But there are things that happen in life that predispose us to prolapse. So it's the way we are born, congenital anomalies. Ehlers-Danlos syndrome, our connective tissue. And then as we grow older in the reproductive age, there is childbirth. Some women may have constipation, some may have chronic cough. And then there are intervening factors, the phase 3 of life, wherein there's menopause, aging, that the change in collagen tissue. And all of these really lead to pelvic floor dysfunction more commonly at the end of life or age. So there are lots of factors. It's not just childbirth. So what can we do? Well, in the antenatal period, women can be advised to do perineal massage. We know from studies that when perineal massage is practiced from 32 weeks onwards, there is a reduction in the need for episiotomy, more intact perineums, and less risk of anal sphincter injury or 3rd and 4th degree tears. We also know that if you use warm compresses during childbirth, there's a reduction in risk of OAC, and this is just taking a warm compress, putting it in warm water, and applying it to the perineum in the 2nd stage. We also know that there's evidence that if manual perineal protection is used, there's reduction in risk of OAC. It almost reduces by half. And selective use of episiotomy, that is doing it only when it is indicated, also reduces OAC by 30%. And if you can avoid using forceps, you should avoid using forceps. Because this is one of the main factors that affects the pelvic floor. It not only damages the levator ani muscle, but also the anal sphincter. High risk. But I'm not saying that you need to throw away the forceps. I think training is important in both instruments, both types of assisted delivery, forceps and Ventouse, and then we select the right thing for the woman based on her choice and based on what is right for her. I'd like to tell you a little bit about the OAC Care Bundle, which is a quality improvement program that we did with the Royal College of Midwives. And we chose 4 elements of a care bundle. So a care bundle is where you put various interventions together. And this included providing antenatal information to women. And this is because women said to us, nobody talks to us about pelvic floor injury in the antenatal period. And we need to get better at that. We included manual perineal protection like they do in Scandinavia, and that's a lecture on its own. Doing episiotomy when indicated and doing it correctly at 60 degrees angle so that you get episiotomy at 45 degrees. And last but not least, doing an examination after every vaginal birth so that you can detect anal sphincter injury. What did we find? Well, we found a 20% reduction in OAC rates where the OAC care bundle was implemented. This was mainly after spontaneous vaginal births, but there was no increase in episiotomy or cesarean section rates. Well, we have recently done some research in the RCOG, and we found that when we asked women, 3 in 5 women had experienced poor pelvic floor health. But they didn't know what to do about it. They didn't know what their pelvic floor was. They had never done pelvic floor muscle exercises, and they were not confident about doing this. But we also had missed opportunities because 69% of women had never spoken to a healthcare professional. So we need to build services around women, and one of the ways to do it is to develop clinics where you see postnatal women who have pelvic floor dysfunction, or you might think of other models. But what we have done in Croydon, where I work, is we have a one-stop clinic where we see women who have antenatal or postnatal pelvic floor dysfunction. If they have anal sphincter injury, we'll do a scan and also pressure studies and provide them with holistic care. We also see women who have FGM and all women who have had OAC in the past, so we can plan their future pregnancy. And we have easy access. We are lucky. We have easy access to physiotherapists, nurses, and colorectal surgeons. But we can also include this in antenatal education, and we can empower women by telling them about the potential risks of operative deliveries. We can educate them about pelvic floor changes that happen during childbirth and what they can do to prevent it. Increase perineal massage, which they can start from 32 weeks, not put on weight. There are things that they can do, avoid constipation. Screen for pelvic floor dysfunction during pregnancy so that you can tell women who are at higher risk. And because also increase education, we know that pelvic floor muscle training is associated with reduced urinary incontinence, anal incontinence. There's grade A evidence. Avoiding smoking, which is not a big issue over here, avoiding constipation, but more importantly, maintaining a normal BMI. And this needs to be part of training. It needs to be part of mandatory training. We need to talk about it. We need to discuss it with midwives and doctors on labor ward so that they are conscious. And if there's one message I want to give you, I know that many of you are not involved, you're not urogynecologists, but this is everybody's business. And if you just ask women when you see them whether they have pelvic floor dysfunction and direct them in the right direction, you will be doing a great service to womankind. So I hope I've covered the various aspects I had told you I would. I've told you what the pelvic floor is. I've told you how it gets damaged, what are the consequences, and what we can do to prevent it. So next time you see an antenatal woman, ensure that you provide a holistic care, not just focusing on the fetus and the abdomen, but also on the pelvic floor. Because as this saying says, this is a famous saying by Socrates, where he said, is the reason why the cure of many diseases is unknown to the physicians of Hellas, because they disregard the whole, which ought to be studied, because part can never be well unless the whole is well. Ladies and gentlemen, I hope I've convinced you that pelvic floor dysfunction is an important and integral part of women's health. Thank you.
Thank you very much, Professor Thacker, for this very interesting and very comprehensive. You took us through the full journey from antenatal to labor to postnatal stages, looking after women to prevent all injuries, whether urethral or anal sphincter injuries. Is there any question for Professor Thacker? Maybe we'll have two questions only, and then we'll... Who? It's Dr. Ismail.
Thank you, Professor Thacker. A very nice presentation. We know if we would like to reduce the rate of cesarean section, we need to reduce the rate of primary cesarean section. And I think we also know that the major damage to the pelvic floor muscles, fascia, ligaments is probably caused by the first delivery. And we also know that the muscle tone is in the pelvis is necessary during labor for the baby to navigate its way through the birth canal. So is there anything specific with regards to the pelvic floor muscles in the first delivery to try and reduce the rate of avulsion or detachment of the muscles? I know this is a hypothetical question. For example, can we give something that will relax the muscle, drop them all floppy in the pelvis, that will facilitate the movement of the baby, therefore reduce the significant damage during the first delivery? Thank you.
Thank you.
Thank you for that really good question. So I think you're absolutely right. The damage is caused during the first birth, and subsequently you can have as many vaginal births as you want to, if you really want to think about it that way. What can we do to prevent it? Well, we have done a prospective study where we were trying to look for risk factors, just as you say, to identify whether anything can be done. And we couldn't find any antenatal risk factors. The only thing that we could find is that when we did pelvic floor scans, if they had a shorter hiatus, then they were less likely to have levator injury. But that is not a practical thing to do in our antenatal practice. So that one was out. So there is a device known as EpiNo, which people have tried to use. So this is a balloon that is put in the antenatal period. Women do it themselves. It has been sold on the market. A randomized study, again, didn't show any benefit. So we don't have anything that can actually prevent this injury, but you can do things like advising the women to do perineal massage. But the most important thing is discussing the pros and cons of a vaginal birth against a cesarean section. And let the woman make the choice. And also informing her that, injury can take place. They can get defects. But I've shown you it's not just about the vaginal birth. It's about the predisposition. It's what happens in life.
Thank you. How practical is in one of your slides that postnatally the problem have to be solved in a multidisciplinary approach, like having urogynecologist, sexual dysfunction person. Is it applicable now in UK, or it can be applied anywhere in the world, unless, or it may be restricted to those whom you suspect they may have some difficulties in the future?
Oh, that's an amazing question. So that is what we do in Croydon, where we have 2 urogynecologists who are absolutely passionate about the pelvic floor. But actually, you don't even need a consultant. You can have a nurse, you can have a midwife who initially sees these patients. It's about asking them the question, about doing the right examination. So you see, I would partly blame WHO for the poor postnatal care, because they have cut it off at 42 days. And therefore, after 6 weeks or so, post-childbirth, women are really not given the importance that they should be given. For example, in the UK, and I don't know what it's like in Jordan, but in UK, at 6 weeks, they get discharged and they're not seen. But most of the problems occur after 6 weeks. Yeah? So injury during childbirth, the symptoms may not manifest immediately afterwards unless it's really extensive tear. Most women don't have those extensive tears. So your question about how we should, whether we need specialists, I don't think so. You need somebody who's interested in looking after these women.
Because we see a lot of urine incontinence a few days or in the first week or two. And we do nothing. We tell them, as what we were taught before, okay, this will end spontaneously after 6 or 8 weeks.
So as soon as they're able to do that, the most important thing they can do is pelvic floor muscle training.
Okay, thank you very much, Professor Thacker.
Thank you.
And I will give the microphone to my colleague, Dr. Ram Shwayat. He's the chairman of the OBGYN department at the Royal Medical Services to present the next speaker.
Our next speaker will be Professor Tom Byrne, is a chair in gynecology at Imperial College London and consultant gynecology at Queen Charlotte's and Chelsea Hospital. He is a co-founder of the International Ovarian Tumor Analysis Group and director of early pregnancy research at Thomas National Center for Miscarriage Research in the UK. He will talk about characterizing ovarian pathology with ultrasound. Please, Professor Byrne.
Thank you very much for the very kind introduction. The introduction may be slightly longer than my talk, you never know. First of all, Jess, thank you so much for inviting me to Jordan. Mazen, it was very interesting to hear yesterday. I think you were saying you worked with my uncle in London. So it's a nice connection to have, I must say. And I've wanted to come to Jordan for many years, so it's just delightful to be here, so thank you. I'm going to talk about classifying ovarian masses, which actually is a large part of our practice. If you look in America, there's like about 250,000 women undergo surgery for ovarian masses, which is estimated probably are not necessary. Often extensive surgery for benign masses that could be left alone. And that's never mind the misdiagnosis of cancer. So I'm going to talk about data from the IOTA study, which of course many of you will not be familiar with. It's a large multi-center study run across about 40 centers. It includes over 40,000 patients, so it has the kind of numbers to allow us to make some reasonably robust conclusions about the best diagnostic tests. And I don't think the pointer's working, but you can see it's gone through various phases, including IOTA 4, which I just want to credit Ahmed Sayazna, who's sitting quietly over there, who recruited all of those patients and when he was at Imperial College wrote his thesis on part of the IOTA study. So Ahmed, thank you very much, and I think he's very well known to all of you. So let's have a think. First of all, this slide tells you everything you need to know. I love this slide, okay? Why do I like this slide? It's because it's about pattern recognition. Most of you, I hope, can tell the difference between a Chihuahua dog and a blueberry muffin. Anyone who can't? because otherwise it could be rather embarrassing over breakfast if you bite a dog's head off. And you can do that because you're super familiar with all of these sorts of things. You see that instantly, you're familiar with it, you can tell the difference. If you fit that into an AI model, they find it quite difficult, because actually a blueberry muffin and the dog have actually got quite similar features. It's actually not so easy, and you can fool AI quite easily. And there's lots of examples with this. I refer you to looking at some types of dog and fried chicken. There's lots of examples on the internet. AI finds it quite difficult. But we are very good at pattern recognition, and that's the basis of ultrasound. And so for this type of cyst, for example, you don't need mathematical models. All of you will be familiar. All of these are just simple hemorrhagic cysts. However, we still see people referred for surgery saying, well, this is, for example, I can't point, but the bottom left one, that was referred as being a solid lesion with unilocular solid and was booked for surgery, despite the fact you just need to repeat the scan in 6 weeks and the cyst will go away. So we have no need for complicated models to classify masses like this. You're relying on pattern recognition and repeating the scan at an interval, particularly in younger women. And when I talk about younger women, one of the biggest issues actually about misdiagnosis is in the adolescent, pediatric and adolescent population, where there's some kind of uncertainty as to who they sit under, surgeons, gynecologists, or pediatricians, and they often get mismanaged. And they often have unnecessary surgery for physiological cysts, or more radical surgery than they need, having an oophorectomy, for example, for torsion or for a dermoid cyst when they don't need it. That's an important group which we need to think about. However, for the rest of the masses, there's two things you can do. I'm going to talk about ways of classifying these. For most masses, you can apply something which we call modified benign descriptors, and they will apply, depending on your population, in between about 30 and 70% of masses. And these are going to be relatively straightforward. And many of these, actually, you'll just identify with pattern recognition. But it's the rest where you might have a problem, and we would adopt a two-step approach using benign descriptors, which will sort out a fair number of masses, and then apply the ADNEX model, which is a mathematical model, to the rest of the masses to classify a mass initially as benign or malignant, but also whether it's, if it is malignant, metastatic stage 1 or late stage. Or, in fact, you can apply ADNEX to all masses. However, there's no need to do that, as I think I'm going to demonstrate to you. So, let's start off with modified benign descriptors. These are all very straightforward and really just an excuse to describe quite common types of mass. So unilocular ground glass, less than 10 centimeters. They're all less than 10 centimeters, obviously describing an endometrioma. Unilocular mixed echogenicity, again less than 10 centimeters, premenopausal, obviously describing dermoid cysts, and basically the rest, unilocular, either with anechoic content or effectively without. So these are all pretty straightforward, but at least we have data that allow you to have a high level of confidence that this is very effective and is accurate. So if we look at this, this is Chiara Landolfo, just to show how this works. In this population, it's, we could apply benign descriptors. It's 4,900 cysts. We could apply the benign descriptors in this population in 37% of cases, so a reasonable number. And almost all of them, as you can see, where we could apply the descriptors were benign, 99.3%. And you can look here with the different descriptors on the left, the likelihood of you missing any type of cancer, and it's extremely low, less than 0.1%, 0.2%, depending on the descriptor. So if you apply these in practice, and you can say IOTA benign descriptor, whatever, 1, 2, 3, 4, applies, it is putting you in a very safe position if you're telling someone it's highly likely to be benign, and if you then make a decision for expectant management and doing nothing, or selecting that patient for example, laparoscopic surgery rather than by a gynecological oncologist, and they can have less aggressive surgery. So that's in a population with a relatively high risk of malignancy. This is Pascal's data from Barcelona, and here the prevalence of malignancy is only 2%, so probably a bit more like what you see in a private practice or an office. Not much cancer, and you can see that it works just as well. If you apply the descriptors in this case, because it's a lower risk population, you can apply them in 77% of cases. So you're sorting out almost 80% of the masses just with benign descriptors, and you'll virtually never get it wrong. Very straightforward. And that's because the prevalence, the type of cysts you're going to see in that environment are largely going to be unilocular, dermoids, endometriomas, that sort of stuff. You're not going to have that many cancers walking through the door in an average practice. But what about the rest? So you apply your benign descriptors, you know you're going to have the right answer almost always. But the rest of the masses you have to make a decision about. And I would argue that we should use ADNEX. ADNEX is a mathematical model. It was developed by Ben van Kalster on almost 6,000 masses, so a reasonable population of masses. It was from 24 ultrasound centers in 10 countries. Not in Jordan, I have to add. But I would say, however, this would suggest that the model is reasonably generalizable, because it's been done, it was developed by lots of different ultrasound people doing in lots of different countries. And the idea, of course, is to discriminate between it being benign or malignant. That's the first thing you want to know about an ovarian mass. But the other thing we do with ADNEX is then subclassify malignancies into whether it's borderline, stage 1, metastatic, or stage 2 to 4. As a gynae-oncologist, Ahmed will tell you now, the options for treatment are changing, and there are options for much more conservative management, particularly for borderline tumors, fertility-sparing surgery. These are now, it's no longer, I'm an oncologist, I saved your life. You need to plan management. And obviously for metastatic tumor, you're going to look for the primary site. So it's not enough to say, I think it's cancer. You need to have an idea of the subclassification and the type of mass that you're dealing with. So the variables, if you do an ultrasound scan that you need to know if you're going to use ADNEX, are actually pretty straightforward. Obviously age is easy. Oncology center basically means, are you in a low risk unit, or are you working in a center where there's a gynecological cancer service? So most people are not working in that type of environment, certainly not, for example, in a private hospital. CA125, the tumor marker, is optional. It makes no difference to ADNEX whether you use CA125 or not. It only makes a difference discriminating between stage 1 or borderline and late stage cancer. Between benign and malignant, you don't need it. So if you scan someone, you don't need to have a CA125 result to come up with a risk of malignancy using the ADNEX model. If you think it's cancer, according to ADNEX, you can then take a CA125, and that will help with subclassification. And then you have these 6 pretty straightforward ultrasound features that you need to look for. And note, there's no Doppler either, which is subjectively often quite tricky. And if you look at these variables, that's easy, maximum diameter. The largest solid part, whether it's sideways, up or down, whatever. Are there more than 10 cyst locules, yes or no? And that's mainly so you can pick out borderline mucinous tumors, which are often multilocular. The number of papillary projections, and I'll point, here we go. And the papillary projection is more than 3 millimeters from the base to the tip. Acoustic shadows, and you can see there, typical cystadenofibromas, and whether or not there is ascites. And these are the only 6 variables you need to be able to get. Okay? Just to look at that in a little bit more detail, I haven't got a pointer, but just to give you examples of solid papillations at the top, you can see measuring from the base, this is more than 3 millimeters, so that's a solid papillary projection. The one on the third down, actually the base is more than 3 millimeters, but the height isn't, so we don't call that a papillation. So you just need to know these minor things. This is about how many papillations, and we arbitrarily say that if the dip between 2 solid areas goes down more than 50%, then that's 1, 2, 3, and you can see at the top it's less than that, and so we would say that is all one papillation. You have to have definitions. So in terms of number of papillations, you need to know these little things. Acoustic shadowing, all rather typical. I'd just point out that if you see this type of shadowing around a lesion, around here, which is called edge shadowing, That's an artifact which you get around cysts, but all the other types of shadowing, typical dermoid fibroma, cystadenofibroma, is something you have to include. I would add, however, although you tend to see acoustic shadowing more often in benign masses, it's not an exclusive sign of a lesion being benign. You see it in cancers as well. And ascites means that you have fluid over the fundus of the uterus for the purposes of aorta, or obviously outside the pelvis, as you can see there. These are, in terms of ultrasound, pretty easy. Let's look at the data just to show how it performs. Not just ignore all the numbers apart from the ones I highlight, and we say for a 10% cutoff for malignancy, in other words, you say it is a positive test result if the risk of cancer is 10% or more. I'll go all the way through to all the data on the right. So sensitivity for cancer is 96.4%, and you have a specificity of 73%, which is the best performing test for the diagnosis of ovarian cancer there is. I won't go too much into statistics, but I just wanted you to have the data. This is a meta-analysis of a number of validation studies. In other words, other people testing Adnex in their clinics, and you can see that the results are actually very, very uniform. The area under the curve, which is a metric we use to evaluate sensitivity and specificity, so the closer you get to 1, the better the test, and if it's over 0.9, it's a very good test. And you can see that overall, the AUC is 0.93. This is very good diagnostic performance. And it outperforms RMI, for example, significantly, or ORADs or any other test you might be using. One of the things is that all these trials on ovarian cysts all look at masses that have been removed surgically. But of course, that's not what we do in clinical practice. We also leave or want to leave masses and manage them expectantly. I mean, there was a time when if someone had a cyst, literally they'd go and have an operation. That shouldn't be the case now. This is the IOTA-5 study. IOTA-5 includes both masses that have been operated on, but also masses classified as benign that have been followed up for at least 2 years. And during that time showed no evidence of being cancer on follow-up scans or presentation. So this is 17 centers, 98 operators, and it's 4,900 masses. But here again, just to show the summary of the data, looking at this mixed group of both conservatively managed masses and masses that have undergone surgery, you can see that the Adnex AUC is 0.94. So in other words, it performs very well in terms of patients who are classified as benign, managed expectantly, and patients who have gone for surgery. So if you classify the mass as benign and make a decision to say, right, we're going to do nothing, or we're going to operate on this patient laparoscopically, not with a gynecologist, you are highly likely that that decision is going to be a safe one and is reasonable. And you have the evidence to back it up because you have a risk of malignancy, and you can inform the patient, and medical legally also, that's a very good thing to have. I'm just going to show this because I just want to say what happens in terms of follow-up. This is the follow-up data where you can see the likelihood of a mass classified as benign followed up for up to 5 years, undergoing torsion, cyst rupture, or being revealed to be a borderline or invasive malignancy. And you can see this scale has had to be reduced to, the likelihood is very low indeed, and I can show you the numbers. First of all, the likelihood tails off over time. You know, you see most of these complications early on, probably because maybe there's, you've missed something on the initial scan and subsequently you realize you have, so they come back as a cancer. If you're going to have a problem, it's going to be in the first few months. But after a while, it's a fairly steady rate. And most of the time, people who want surgery, it's actually the patient's choice rather than because they've actually had a complication. And these are the numbers. It's quite surprising because, I certainly felt that you'd have more complications. But if you look at the likelihood of torsion, cyst rupture, and so on, it's actually very low if you're just looking at acute complications. And I think this is the best data on this. It's 5-year follow-up, which is quite difficult studies to do. And the likelihood that you're going to have missed a significant cancer is also extremely low as well. And I think this is really important data to be able to counsel women appropriately. You know, we've classified this as benign or risk of X on adnex, and we're comfortable to just follow this up and avoid surgery. So this is an important part of the picture. Does all this work in the real world? Because obviously people like me tend to stand up and we've got lots of time and we sit in university hospitals drinking coffee, doing nothing useful. This is a study in the NHS in the UK, the most dysfunctional health service in the world, as we all know, anyone who's worked there. And this is 1,200 postmenopausal women, 23 hospitals. And this was Sudha Sundar in Birmingham and published recently in Lancet Oncology. I know this looks horrible, but the recommendation was aorta adnex with a 10% risk should be the standard of care for the diagnosis and of cancer and the evaluation of ovarian masses. And this is, again, an AUC curve, which looks terribly complicated. But the blue line is adnex. The line furthest to the top left is the best performing test. And actually, you can see that in the hands of these people, I think the AUC is about 0.91. So in the real world practice, which is difficult, pragmatic study with hundreds of sonographers, issues around training, all the kind of practical stuff that happens in the real world, the test works. And you can then link that up, if you want to ORADS, which, as you know, is more of an American system that guides management. So if you apply modified benign descriptors, your chances of cancer being there well under 1%. So in a patient like that, almost certainly benign. You can use that if you want. Obviously, in Jordan, you'll have your own management protocols. I'm not saying this is correct. This is what they like in America, but it's all about local protocols. So this patient, after conversation, you may want to do nothing. Depending on these risks, the thing about ORADS is it gives a very wide risk. With adnex, you get an exact risk. So you'll say it's 7%, 8%, 9%, or whatever. Based on that, you will then refer the patient for gynecological cancer surgeon to evaluate. Or you might say, look, if the risk is relatively low, depending on what protocol you discuss with your gynae cancer people, what people are comfortable with, you may say it's okay to have laparoscopic surgery. Let's say the risk is 8%. You might accept that as being reasonable, but you might say if it's 20%, they have to see a gynecological cancer surgeon. That's, for you, that's going to be different in whatever clinical environment you're working in. But you can then link your risk to clinical management protocols in a reasonably effective way. And if you look now at the European journal, this is the British Gynecological Cancer Society. They have now recommended that adnex be used. They also still hang on to RMI as well, because trying to stop people measuring CA125 is rather difficult. But you can see in triage to secondary care, they recommend the two-step strategy, simple descriptors.
Professor Tom.
Okay, I'll be quick.
Professor Tom.
Yes?
3 minutes.
Yeah, don't worry. And then IATA adnex as the second stage test. If we look at the overall performance of the two-step strategy, just quickly, you apply benign descriptors, you get 37% of tumors, I've shown that already, high test performance. And then if you look at the whole strategy, benign descriptors plus adnex, the AUC, as you can see here, 0.94. So the two-step strategy, very, very good test performance, and I'd recommend that to you. So, very quickly, this lady, just to show how it works, you can see this is a solid mass. What is it? Ahmed, you can tell. What is it? I haven't got time, mate. Okay, it's lobulated mass and it's vascular. That tells you what. So it's one of those. Okay, you put it into adnex. I'm just going to go through this. You fill in the variables, and you've got this information. This is the information, and it will tell you that it's malignant because it's a risk of 31%. So it's over 10%. Then subclassifies. It says that at stage 1 ovarian cancer, the odds are the highest as it's stage 1. So what's going to happen? It's intermediate risk. We'll go to a gynae-onc, and this is a dysgerminoma, classic dysgerminoma, because it's lobulated. If you see where those dots are, And just to say, there are some of these solid, more rare tumours which are actually quite characteristic. Swiss cheese, granulosa, dysgerminoma, classically lobulated, fibroma, you'll all know, with fan-shaped shadowing. This isn't so, but that's an immature teratoma, chaotic, solid mass. So, benign descriptor, really straightforward, easy. Look, that's the one. What does it apply? That. So, it's an endometrioma. So that's how it works. Very quickly on A, sorry Mr. Chairman, just to illustrate where things are going. This is AI. Back in the day, you couldn't sort out a blueberry muffin. Now, if you put it into ChatGPT, tells you straight away. So who knows? In fact, it'll do it quite well with ovarian cysts as well. However, if you look back, using AI now to classify ovarian masses, once again, you can see Ahmad was there. I remember when he was a fellow saying, we've got to do AI. And of course, I think this is one of the first publications on AI to classify ovarian masses. Cassandra was the statistician, Ahmed was the clinician who drove this work. IOTA AI, 2,500 patients. This is talking about automatic segmentation. You can see the AI identifies the adnex features. And if you look at the performance of automated segmentation, where the AI is able to recognize the features automatically, you just put the scanner on, you can see that at the moment the AUC is 0.9 compared to 0.93 with a clinician. So we're almost at the point where you're all out of a job. Sorry about that, but there we are. So, and this again is multi-center and generalizable. So I think within a year we'll have an algorithm that will be in the machine where it automatically identifies the abnormal area and will basically tell you what's going on. I'll finish on that. I'll just draw your attention to a couple of studies we're doing. Anyone who wants to take part in a study looking at masses in young women or pregnant women, do let me know. And I will finish there. And once again, thank you very much for having me. I'm sorry I'm over time, Mr. Chairman. My apologies.
Thank you. I think we have time for 2 short questions. Dr. Abir.
You ask all the questions, I know, I can tell. You're
I have to be a motivator. So after the first question is asked, there will be more questions asked. So do you use a 10 centimeter diameter to say yes or no, to interfere or not to interfere? Is this a diameter? If it's 12 and looks simple, you just wait.
Yes.
If it's, why 10 centimeter?
Well, the 10 centimeters was for simple descriptors, looking at benign versus malignant. So it might not be always the decision whether you manage the patient expectantly. There's 2 factors involved. One is the likelihood of an acute event, concern about torsion or whatever, for example. I didn't have time to show the data, but without doubt, if you look at the IOTA 5 data, once you get up to over 7 centimeters, the risk of torsion does go up, but it's still only about 2 or 3%, so it's not huge. So you can have that conversation with the patient. We happily leave cysts of 10, 12, 13, 14 centimeters, particularly in pregnancy. We wouldn't intervene. In terms of the classification with the descriptors, we've simply found that when we analyzed the data, because we based on the statistics, that for masses over 10 centimeters, we did miss a couple of cancers. And we think it's probably simply because of the size, we missed some solid papillations when we scanned them. So I think you just have to be very careful that you examine the whole mass. And I think when you're talking about an algorithm that everybody uses, I think it's safer to keep it at 10 centimeters. So for simple descriptors, 10 centimeters is the cutoff. But there's obviously clinical discretion in terms of other types of mass. If you're very confident it's a dermoid cyst, for example, we would not necessarily have any firm cutoff. It would depend on the clinical situation. Although, most dermoid cysts over 10 centimeters we're probably going to remove. But we wouldn't necessarily if they're pregnant, for example.
Thank you. Anybody else?
Dr. Assam, please.
Dr. Assam, sorry.
Just short question, please, because of the time.
Thank you very much for your comprehensive presentation. Now, regarding the IOTA, it was weak in discriminating the borderline type. It was good to discriminate between benign and malignant. Maybe the adnex was modest accuracy with this. And the other issue, it's...
Hang on, not true. discriminating between borderline and malignant is fine. Sorry, but borderline and benign is not an issue. The issue around subclassification is discrimination between borderline stage 1 and metastatic. So if you include all borderlines in the malignant group, the discrimination is maintained. So it's not modest.
The IWATA, I'm talking about the IWATA, it was weak.
IOTA?
Yeah.
The
ADNEX was...
I wrote the paper. It's not weak. It is, you've analyzed invasive and borderline against benign, and it's the same.
Never mind. The other issue, it said an operator-dependent classification. This is another issue. So there is a difficulty to apply this.
Well, can I stop you?
Just 1 second.
No, you've made 2 points, so I'm going to reply to you, okay? The second point you make about being operator-dependent is dealt with by the fact that it's multi-center. That's the point of the trial design. So if you have multi-center data, for example, IOTA 5 is over 100 plus sonographers in multiple hospitals. And the point you made was the whole point of the trial, which I showed by Sudha Sundar in Lancet Oncology. It's a real-world trial in the NHS with sonographers, no special training, no special unit, and you can see that the AUC was over 0.9. So, which is why NICE is going to adopt it. So we don't have an issue with it being operator-dependent.
Okay,
so
thank you, Sam.
Combining, just one second, I didn't ask. He interrupted me many times before I finished my question.
It's only, we have to stick to our time because we have the
So if we combine the tumor markers and the AI, I think we can get better discrimination and better clinical application.
Yes, it's interesting you say that, but obviously we looked at that and it doesn't actually, CA125 doesn't improve the performance of the AI because we've done that study. And we've also looked at HE4 and the Roma test, and Roma test does not improve the performance of the ADNEX model. So I totally agree with you. I would have thought the same thing, but when we've actually done the trial, it doesn't help. So unfortunately, no, it doesn't. And we've also looked across the IOTA trial at multiple biomarkers and published those as well. And we found no improvement in test performance with all possible biomarkers currently known, including using liquid biopsy. We've looked at all of those. So it's a nice idea, but unfortunately, currently with what we know, it doesn't work. Okay?
Okay, thank you very much, Professor Bourne. And we'll see you after the next speaker. Sorry?
You promised her that she will answer.
I'm sorry, just a short question. Thank you so much for this super valuable lecture. No, very short one. And it's about how we apply for the IOTA system. I saw you, you were filling the data in, like, I don't know, it's an application on the phone or it's in a website. So just to clarify the...
Yeah, there's three... It's actually, ADNEX is actually built into quite a lot of the ultrasound machines now. I don't know what machine, some of you will be familiar. I think I was talking to a few people last night over dinner and they said, well, we've got it in the machine. It's an online web application and there is also an app, okay? It hasn't been available recently because recent law changes meant that you have to have medical device regulation. So models are now treated as medical devices, which have to go through a process like going through the FDA in America. So we had to block use of it because we had to get medical device approval, which we're just getting now. But you know, I can tell you, if you get my email off the organizers, I can show you, I can send you a link. I mean, I'm sure someone can do that. I'm easy to find on the internet, so just drop me an email and I can send you a link quite happily. Yes, free of charge.
Okay.
Obviously to you, to him, it's very expensive.
Thank you very much. May I introduce the next speaker, Dr. Mohammed Hassan. Mohammed Hassan is a consultant gynecologist and head of obstetric and gynecology department at the New Cairo Hospital. He's going to talk to us about lateral suspension technique for pelvic organ prolapse. Please, Professor.
Thank you again, Mr. Chairman, ladies and gentlemen. I'm very proud and happy to present again in this respectable Congress. And today, I would like to speak about another technique or a different technique to treat pelvic organ prolapse. So let's start with what is the pelvic organ prolapse? Is it uncommon in practice, or we can see many cases like that in our practice, and sometimes we may be trapped how to deal with these situations. The pelvic organ prolapse is a condition where the organs, the internal organs, like the uterus, the vaginal walls, are below its normal level. So one or more organs like vagina, uterus, bladder or rectum as well, to sag down below. In more severe cases, an organ may be bulge outside the vulva and leads to many long-term consequences. In most of literatures, we believe that the incidence worldwide is about 20%. And regarding the vault prolapse, particularly after hysterectomy, the RCOG states that it's about 2% after hysterectomy for benign causes and may reach up to 11% after hysterectomy for malignant causes. The traditional management of prolapse, we can go for conservative measures, like if the patient have a grade 1 or a mild degree of uterine prolapse or vaginal prolapse, we can offer her a pelvic floor muscle training. And if the patient is unfit for surgery, for example, or refuse doing a major surgery, we can offer a pessaries. We can also think about preventive measurements. For example, if we are going to do a vaginal hysterectomy, so in the vaginal hysterectomy, we can offer a McCall colpoplasty, which will help to prevent further possibility of vault prolapse. This is very well known. The same technique of McCall colpoplasty, when the vault is sutured and supported to the cardinal cervical ligaments and uterosacral ligaments, can be done through abdominal route with abdominal hysterectomy with Moscovich procedure, and we can also, or additionally, close the Douglas pouch, preventing further possible enterocele. The curative measurements are very well known to all of you. If we have a prolapse, either vault prolapse or uterine prolapse, we can manage vaginal route by sacrospinous fixation. Or if the patient is sexually active or she had a short vaginal wall, we can do abdominal sacrocolpopexy or abdominal hysteropexy. It depends on the situation. All of these measurements are very well known and evidence-based established in the practice. So where is the point? Let's do a very rapid evaluation about the SSF, sacrospinous fixation, and abdominal sacrocolpopexy or laparoscopic sacropexy. In the SSF, it interferes with sexual activity somehow because of the deviation of the vaginal axis, and it's not suitable with short vagina, as we said. Most of patients, around 20% to 30% of patients, will have a severe chronic pathoc pain after the sacrospinous fixation. There is, as usual, a risk of injury to the pudendal nerve, inferior rectal artery during the procedure itself. However, it requires skills and training. The same in laparoscopic or abdominal sacrocolpopexy, bleeding, infection, using a mesh, complications, painful intercourse and deep dyspareunia, and it definitely requires a long time curve of training to be confident enough to conduct this procedure alone. What we are offering is a simple technique that gives a very good results, and this is the classical sacrohysteropexy or colpopexy, just to dissect posteriorly the retroperitoneum to read the anterior longitudinal ligament posteriorly, and then use a mesh to suspend the prolapsed organ to the back. Now, sorry. The lateral suspension for BOP. The technique may be done laparoscopically or through abdominal incision. And it was first time described by Dephenson in 1998. What we can do is, we are using a mesh, like in the picture, and we are applying the two arms of the mesh on the prolapsed organ, either the uterus or the vagina. And then the two arms will be grasped out laterally through the abdominal wall and the external oblique aponeurosis in the point which is 4 centimeters lateral to the iliac spine and 2 centimeters above. And the mesh will be placed there. The steps will be done through a small cut incision. 2 small cut incisions are made 2 centimeters above and 4 centimeters again lateral to the anterior superior iliac spines. Through these incisions, a laparoscopic atraumatic forceps will be introduced and perforating only the aponeurosis of external oblique muscle. I will never get inside the peritoneal cavity. I will just penetrate the aponeurosis, and then I will stop at the peritoneum itself. The forceps advance caudally and retroperitoneally, passing under the ipsilateral round ligament and existing through the peritoneal incision. On each side, the distal end of the mesh arm will be grasped out and then will be got out at the lateral incision we did. I will show you an example for this very simple technique. And then, most important advantages with lateral suspension, the learning curve. After 5 to 10 procedures, you will be able to do it alone, confidently, without supervision. It can be done also through a very small abdominal incision, and it can be done for either suspension of the uterus body or the vault. Some supporters of sacrocolpo or sacrohysteropexy criticizing this procedure because it doesn't give the support enough to the posterior vaginal wall. However, the risk of rectocele or weakness of the posterior vaginal wall after this procedure is very low. We believe it's about 0.2%. This is an example for how much the abdominal incision is very small. And this is a case with ultrasound scan after 3 weeks of lateral suspension. Please notice here the position of the uterine body after the hysteropexy. It's typical like natural one. The AVF position is a very critical advantage of this technique instead of being somehow backwards in sacrocolpo or sacrohysteropexy. The technique again is very simple. In these pictures we can see the application of the mesh on the vault after opening the uterovesical peritoneum. And then traction of the mesh arms beneath the peritoneum. In this one, I get the atraumatic forceps from outside in. Just after penetrating the external oblique aponeurosis, I went beneath to the peritoneum without any perforation in it and get inside the peritoneal cavity under the round ligament incision after hysterectomy. Then the next step is the final step is, after grasping the arms backwards under the peritoneum, is just to cover the mesh with the peritoneum to prevent the major risks of erosion. Let's see live surgery. Yeah. Now, in this step, actually, we are, I will come here. We are trying to first identifying the vault, and this is the bladder, and this is the vault from down below, and then I will do an incision in the peritoneum covering the vault here. I prefer to use the cold knife instead of any electrosurgery. And then after completely dissecting the peritoneum, this is the vagina, the walled vagina. Yes, this is the vagina. And then application of the mesh. Fixing it, 2, 3 Prolene sutures, non-absorbable sutures. And then the arms of the mesh will be grasped beneath, exactly beneath the peritoneum. And then the 2 layers of the peritoneum will be sutured together to bear down the mesh. Using the same, you can use here the vicryl instead of the permanent sutures, and then the mesh is completely covered successfully. This is a very simple technique, and the evidence regarding this technique, of course, we need more studies to confirm this idea, but in 2021, a systematic review, a large systematic review, shows the simplicity, safety, efficacy, and visibility of minimal invasive lateral suspension with optimal anatomical and functional outcomes. In correction of pelvic floor prolapse, most of surgeons are looking for correction of anatomy, but actually you have to think about the function, because it's very important to restore the urinary function sometimes, sexual function, and bowel function. Regarding the quality of life after the LS, the patient satisfaction after laparoscopic lateral suspension with mesh, the conclusion was it's a safe technique with promising results, and most of patients were very happy about that. Regarding the associated possible urinary symptoms after LS, which is most commonly overactive bladder, let's see that the assessment of overactive bladder after laparoscopic LS, the conclusion was its effective procedure for apical and anterior vaginal wall defects, and it shows that there is no significant differences between the classic sacropexy to the LS technique. Also, regarding the risk of the nightmare of using mesh, the mesh erosion risk, incidence and risk factors for mesh erosion after laparoscopic repair of LS, it seems like the erosion is very low risk and may be further reduced by using appropriate mesh materials. The technique is critical to avoid the mesh erosion. And in that way, sometimes, if I have, in my practice, if I have a deficient peritoneum and I'm unable to coaptate and cover the mesh with peritoneum properly, I may sometimes use an omental patch to ensure that the whole mesh is covered safely. Okay, another modification of classic LS, and this modification is we use it sometimes when some of our colleagues is not enough confident in laparoscopic sutures. He's not happy to take too much sutures by laparoscopy. So we thought that the modification of LS will be much easier for most of physicians. The aim is to facilitate suturing the stem of the mesh to the vaginal apex, and it can be only done after hysterectomy with a vault. Okay, a new combined laparoscopic vaginal lateral suspension procedure. Combined technique, laparoscopic and vaginally in the same time. I will show you the technique, full technique. We used to name it as VALS, Vaginal Assisted Laparoscopic Lateral Suspension. I think you will enjoy this video, which explains how can we apply the mesh vaginally and then grasp it upwards with a laparoscopy as well. let's start. Again, this is a vault prolapse. And, identifying the vault, opening the peritoneum again by the same technique, taking care about the bladder, and then identifying the whitish tissue of the vagina. This is the cup, vaginal cup, down below, and this is the vault. Try to dissect all possible tissues to ensure safety of the bladder. And then do a simple incision in the vaginal vault. All of you can do that. It's very easy. And then from down below, take the lips and suture the mesh from vaginal root, reinsert the mesh back again, grasp the arms by a laparoscopy, and then do the same idea, arm beneath the peritoneum, another arm beneath to the peritoneum, and then it's very clear edges to be sutured easily. And if the sutures are still difficult with you, I think the V-lock will be easily used in this situation, and then the mission is accomplished. Still, we have a lot of time and we need more studies worldwide, multicentric, and we have to wait at least for 10 years waiting for possible long-term consequences prior to 100% use it like an evidence-based procedure. But I think it's a promising procedure and helps many physicians and gynecologists to achieve a proper treatment for BOB patients in their practice safely with a very easy learning technique. Thank you so much. On time? Yes, on time.
Thank you, Professor Hassan, for very nice videos as well.
Thank
and
you.
Very nice presentation. Is there any question? I think our colleagues, the urogynecologists, they like to have a
No question? Yeah, okay. Because
Thank you for this nice presentation.
Thank you so
Do you
much.
think it will correct cystocele?
Now,
As
now it's prescribed for apical prolapse mainly, and of course it has some impact on stretching the vaginal anterior wall during the correction. It's definitely leads sometimes to weakness of posterior wall, but it's not described as a treatment for anterior compartment prolapse, the cystocele.
so the number of cases you will treat will not be large, because most of the time you will not find an isolated uterine prolapse alone.
It's sometimes it's isolated, and it's associated sometimes also with a mild to moderate degree of cystocele. So the mild moderate degree will be automatically corrected. It's the same idea with Birch-Kalpoe suspension, and it depends on the type of cystocele. Just a point to be explained. Cystocele, it could be a central defect, and it could be a paravaginal defect. Okay, so for example, if we have a central defect when the vaginal rougets are absent, yes, of course, cystocele correction is ideal vaginally. The anterior compartment correction is ideal vaginally. But if we have a paravaginal defect, now the Birch-Kalpoe suspension will be ideal to correct this defect with SUI. This is the same idea to do it laparoscopically with pulling up the vault or the prolapsed body a little bit, so it will help in the correction.
Thank you. I have one or two questions. You know, pulling it up, does it interfere with patient's movement, feeling pain in the abdominal wall?
Thank you so much for this very good question. That's why it's called suspension, not fixation. So the traction should not be maximum, and you should leave a space of mobility, a natural mobility of the prolapsed organ. So we will never pull it up to the max. We are just supporting it like suspension, not fixation, to the anterior abdominal wall. So it allows movement. If the patient is coughing, running, doing whatever she wants, she will never feel any problems.
Is it going to be affected by changes in body weight, obesity, or future pregnancy?
I don't believe that because it doesn't depend on the PMI of the patient. It's fixed in the fixed point in the sheath itself. So the sheath will not
Overstretching of the abdomen with the pregnancy in the future.
No, it will be like a fatty layer which is increased. Now the sheath is fixed.
Any question from the Professor Thacker, please?
I'm waiting for your question.
No, thank you very much for that really nice
I didn't say
presentation.
it's evidence yet. Okay.
Yes, exactly. So great presentation, and I do think we need to be thinking about innovations in urogynecology, because since we have had the mesh debacle, I don't know how intense it is over here, but certainly in the UK, we have lost one of the best procedures that we have for women with urinary incontinence, which is TVT. So we need to be responsible when we introduce new operations. And I can see your technique is good. I can see also increased mesh erosion in a woman who has had a total abdominal hysterectomy, because there's quite a lot of mesh on top of the wall. So how many have you done? What are your plans for publishing that? And what are the plans for a randomized study?
Now, thank you so much, Professor Rani, for your question. Yes, I know that I'm getting inside a very difficult area, especially in presence of you. So what we believe in, myself, I had 11 cases myself, and the team in Kasr Al Aini Hospital in Egypt, Cairo University, I think we were able to do about 44 cases. However, we have more plans to establish more cases and start to publish a study once we reach a respectable number of cases, like 70 or 80 cases. But the problem is waiting for complications. So at least we need to follow up the patient for a year, okay? Waiting for any possible complication regarding the sexual function, abdominal pains, mesh erosion, and its complications. Now already, the lateral suspension, we have published papers like I showed in my presentation starting from 2016, but it's still under evaluation, multicenteric, and I believe within 2 to 3 years this plan will be completed and this kind of procedures will be published in a clear way. It may be being an evidence one day, I'm not sure, but from my practice and for following up 11 cases, I'm feeling very happy. Patients are very happy, especially that removing a womb in our culture, in women in our culture, is sometimes unacceptable. So that I need to find a possible alternative, which is easy, safe, and the learning curve. You know, one of the most critical issues, the learning curve of sacrocolpopexy. One of my seniors always saying that it's not about the procedure, it's about how can you deal with complications.
Dr. Hassan,
I'm
we
sorry.
are late.
I'm sorry. Thank you so much. Appreciate it. Thank you.
Our next speaker will be again Professor Tom. He will talk about the diagnosis of miscarriage and features that predict management. Professor Tom, please.
Thank you so much. Oops. Are my slides? Yeah, okay, well, miscarriage. I mean, seemingly straightforward. I think I've gone on. Yeah. Well, first of all, thanks once again. Lovely to be here. And I'm going to talk about something which I guess everyone deals with. It's almost as if it's, you know, how hard can it be almost to diagnose miscarriage? However, I would put it to you that if there's one diagnosis any woman would expect you to get right, that would be if their baby has died. And I think I use the words baby has died advisedly, because if, what am I doing? What? There. There? There. Do you want me to eat it? No. Okay, so my apologies if you couldn't hear me earlier. I was just saying the importance of getting that diagnosis right. You tell someone that they've miscarried, you know, as soon as someone has a positive pregnancy test, their whole outlook changes. And miscarriage isn't just, well, it's the loss of a baby, but it's the loss of a whole kind of almost vision of what's happening in your life. So it's a very profound issue, and we'll talk a bit about the psychology later. However, there are some themes. If someone's told they have a miscarriage, the questions are, you know, always, you know, what did I do? You know, is it my fault? How common is it, and what can I do to stop it happening again? These are the very common things that are asked, and there's a major bit of, you know, self-blame and so on is very, very common. And there has been more of a focus on research connected to miscarriage, and this is Ari Kumarasamy and Siobhan Quemby in the UK, and it's an interesting series that we wrote in the Lancet called the Lancet series, where there's a big sort of meta-analysis of all the available data, and we are getting some indications to help us understand why miscarriage may be happening, and we are looking now at things around things like the microbiome and so forth that may perhaps offer us some options therapeutically. But when you look at the burden in the world, 23 million miscarriages each year. So in fact, we know now that the pooled risk is about 15% of all pregnancies. So 11% of all women. So undoubtedly in this room, of course, there will be people who've had a miscarriage. And the overall cost is probably about £500 million a year. We do know some risk factors now. I won't bore you with all of this. There are some interesting things now around air pollution, working night shifts increasing the risk of miscarriage, which I think has major implications in many workforce issues. I can see Kate Lancaster at the back there. So if we show that night shifts increase the risk of miscarriage, high stress, overworking more than 40 hours a week, no one wants to go there because I think it's just a bit too difficult. We're just beginning to see now companies and indeed governments offering time off after miscarriage for the first time, which is long overdue. However, watch this space. Slightly off topic, but I think it's interesting. However, what you don't want to be is in this situation. Certainly in the UK, it's not an unusual situation to see someone come for a scan having been told they've had a miscarriage, and they haven't. And if that does happen, you've got a fairly good chance of ending up in the newspapers, which is never a very comfortable place to be if you're a doctor. I can tell you, I've been there. So you don't want to do that, I think. I don't know what happens in Jordan, but the newspapers in the UK are quite aggressive, and they won't hold back, that's for sure. And I think they would expect, quite reasonably, that this is a never event. The thing is, it isn't. And one of the problems, and this, I'm sorry about the slides, a bit blurry, but if you look, this is Cecilia Bottomley showing that by gestational age, if you come for a scan, for example, at about 36 days for 6 weeks, the chances of having a diagnostic scan are actually quite low. It's about 10, 15, 20%. If you go up to 42 days, it's about 50%, and even at 7 weeks, it's only going to be up to about 80%. What does that mean? It means you have to make a decision, because it's either going to be a pregnancy of unknown location, you can't see anything, or it's going to be a pregnancy of unknown viability. In other words, you see a gestation sac or an embryo, you don't know if it's viable, and you have to bring them back for a further scan at an appropriate interval. But there is an opportunity to make a mistake. It exists. And you tell someone they've miscarried when they haven't. And if they opt for medical management or surgery, obviously the consequences of that are a disaster. And it's not helped actually by these sensitive pregnancy tests, people turning up, you know, for scans because they've had a bit of spotting or bleeding before they're even due to have a period. And they come up with a positive test. Obviously, they want to have a scan. You scan them and you don't see anything. It's a big issue for us, certainly. And I think this does create a lot of iatrogenic problems. Now, I think the assumption would be that diagnosing miscarriage, the criteria would be safe and well worked out. If you go all the way back to 2011, this is a systematic review by Jave, which was published. And quite alarmingly at that time, you'll see that this was the data on which the guidelines were based at that time. And all of these were very small studies. And if you look at the specificity, so the false positive rate, the confidence intervals were extremely wide, and in some cases leading to a possible false positive rate for the diagnosis of miscarriage of 35%, maybe 12, 7, but you get the picture here. Here we have a test to diagnose miscarriage where you'd expect there to be no false positive tests. You wouldn't expect to say you've got an empty sac of X, you've had a miscarriage, find out that in fact it could be wrong. But in fact that was the case. This is just the same data shown on a different slide, which I somehow put in by mistake. Also, we come to this issue of operator error. If you look at the inter-observer variability of measuring an early pregnancy, this is Ann Pexter's study, and you can see here, just looking at CRL, at that time in the UK, CRL was used to measure the embryo as a criteria for miscarriage, defined by 6 millimeters, but it could be 5.4 or up to 6.7 because of inter-observer variability. And if you look at the mean sac diameter of 20, which is what we used, there was a big range, almost 17, 16.8 to 24.5. So if you measured 20 and you said 21, you had a miscarriage, well, you might be wrong. And the problem is, you're measuring with the gestation sac in 2 diameters. You're having to turn the probe, and it's obviously likely to cause a problem. So you do have to be careful. We then carried out this study. I won't go into huge detail because it's slightly historical, but I think it illustrates what I'm talking about. Over 1,000 women in several early pregnancy units in London, and I'll show you the data. And I should add that this was carried out by Yazan Abdallah, who's doing his PhD. Yazan now runs an IVF unit in Doha. Some of you may know him, I don't know, but Yazan did his PhD with us. And he showed the following. Looking at the cutoff levels, if you look in America at that time, they defined miscarriage as being an empty sac of 16 millimeters or more. However, you can see that in fact, the false positive rate for miscarriage with that was 1 in 20, which is amazing. Yeah, it's just ridiculous, and actually could be even worse looking at the confidence intervals. In the UK, the false positive rate was about 1 in 200, which obviously is much better, but again, with quite wide confidence intervals, it could be a lot worse. So clearly that cutoff is not acceptable, and that's not even taking into account inter-observer variation. If you look at CRL, in that time, the United States used 5 millimeters, and again, about 1 in 12, based on that, could potentially have a misdiagnosis. I mean, that's pretty dreadful. And you'll be amazed to hear that within about a week of the Abdallah publication, Rene, have you ever heard of this? The college changed their guidelines within 7 days. That's quite something. So in fact, the college was extremely responsive because I think they recognized that this was potentially quite an issue, because unfortunately we didn't want this to get into the newspapers, but it kind of did. And of course it was all, dead baby type thing, and we knew that we had to have something to say. But the guidance changed from 16 or 20 or 5 or 6 to a cutoff of 25 millimeters and a crown rump length of 7. So that's why all of you probably here, I'm sure, are using those cutoff values, because that had to change. However, it's just a cutoff value, which is why we always say, always have the diagnosis checked by a second operator. So cutoff values are fine, guidelines are fine, but when you're making such a critical decision, whoever you are, it is advisable to have it checked by someone else. So get a second operator to check the scan, just like you would anything else in the event of making a diagnosis of miscarriage. Now the other thing, of course, where actually there was a big gap here, and if you look at college guidance and NICE, it was reasonable. They said, well, look, if you're not sure, in other words, if it's under the cutoff, if it's 20 millimeter empty sac or 5 millimeter embryo, what do you do? And they said, well, come back and have a scan in a week. But if you ask people around the world, you say, when do you bring the patient back? They say, oh, 10 days, 7 days, 14 days. Now, there has to be a right answer. Because, again, if 7 days isn't long enough, you are potentially not allowing time to evolve. And this was not based on data. This is just based on people being sort of making a sensible guess. And that's quite surprising when you're talking about whether your baby's dead or not, isn't it? When you think about it. I mean, it's quite sensible, but it's not evidence-based. This led to this paper in the New England Journal as well, which Peter Duboulay put together. They asked me to take part, and this kind of base is what they use in the States, and this consensus paper is how they developed guidance in the States, and then they totally followed, if you like, the data that we'd produced. And they said, quite reasonably, they said if there's no embryo or the heartbeat 2 weeks after a scan that shows a sac without a yolk sac, in other words, wait 2 weeks. And if there's an embryo with no heartbeat, they said wait 11 days. So they were a bit more conservative, for example, than we were in the UK. But they also put up this list of findings that are suspicious for pregnancy failure. And I think one part of my talk, the topic is, what is risk factors for miscarriage? And you'll all be familiar with this. I mean, basically, if you see an embryo with no heart rate, there is a high risk of miscarriage. It's more likely to miscarry than not. But that doesn't matter. If you make a diagnosis of miscarriage, you can't get it wrong. So the fact it's at risk doesn't matter. You can say to your patient, look, I'm very sorry, I'm not optimistic, but we have to bring you back. Because we have to be certain. I hope you understand that. And they do. That waiting is undoubtedly psychologically not good for them. But I think people understand, and people want certainty. If you say, well, look, you do want us to be certain, and they do. Occasionally not, actually, but 99.9% of the time. Similarly with an empty sac, an empty amnion, if you've got a large yolk sac, these are all markers of likely poor outcome, but are not diagnostic. So they can help you say, well, look, I'm sorry, it doesn't look great, but we'll have to bring you back and see what happens. So things like this, you look at a scan like this, and you know this doesn't look okay. And you kind of think, this is not going to be okay. But again, just because you have a small sac to embryo ratio doesn't mean that you can say this is a miscarriage definitively. Unfortunately, you do have to wait given what we know at the moment. Hematomas, this is something else people get worried about. You're all familiar with these sort of subchorionic hematomas that you see. And understandably, people measure them, and the patient finds out, and they worry. But an intrauterine hematoma does not increase the risk of miscarriage, independently of the fact that they are bleeding, usually. So if they're bleeding, fine, that's a risk factor. But the hematoma doesn't make it any worse. What it does do is increase your risk of antenatal complications in general. If you have a large hematoma, you've got a slightly higher risk of prematurity, excuse me, IUGR and so on, if you look at the data. But in terms of early pregnancy, it's not a marker of miscarriage, and it's certainly not diagnostic. And I'll just say something, again, to be careful about is chorionic bumps. You do see them from time to time if you scan early pregnancies, and it's actually quite easy to see how, if you're not familiar, you might measure one of these and think it's an embryo, perhaps. I mean, I've seen it happen that people have measured what you can see on the right and the bottom left. That's the embryo, but they measure it. It's about 18 millimeters, and they say it's an embryo with no heartbeat, and they say it's a miscarriage. I know that may, for those of you who experience scans, be ridiculous, but we do see it. People worry that this means they're going to miscarry, and there is probably an increased risk of miscarriage. There's not many studies, very tiny numbers, probably an increased risk of miscarriage, but it's not necessarily a disaster. Probably more likely than not, it'll end up with a live birth. We're not really sure what these are. They're not hematomas. They might be, we don't know. But you can see in some of these, the top left, this was measured as a CRL, as an embryo, and she was given a diagnosis of miscarriage. And so, with the eye of faith, you might see how people just might get it wrong if they're not being careful. So just be aware. It doesn't happen often, but it is a source of misdiagnosis. So we had the Abdullah paper. It was 1,000 patients. And we wanted to go back to that paper because the confidence intervals were quite wide still in terms of an unacceptable potential rate of false positives. So we had Jessica Preisler, who came to work with us. Great friend of Ahmed's. Worked together, did you not? Still good friends. Excellent. And Jessica enlarged or extended Yazan's data to 2,500 women. And you can see from the cutoffs at 25, we were able to tighten up these confidence intervals to show 100% specificity and a confidence interval of 99 to 100. And I think to get them up to 100 to 100 would require thousands more. But I think that's reasonable confidence, that that's not, not a reasonable cutoff. And so it's interesting that when you look at, the Dubélé paper and we look at what the college did, these cutoffs actually were perfectly reasonable and I think safe cutoffs. Although I haven't shown the data for MBO, the same thing applies there. So the question then is, what about the follow-ups? So we confirmed that this is perfectly sensible. There are a couple of things worth pointing out. First of all, because we had good data on follow-up, we were able to say, with a fair degree of confidence, and you can see the confidence intervals there with 100% specificity, that if you have an MBO with no heartbeat, if there's no heart activity 1 week later, if you bring them back for a repeat scan, it's a miscarriage. Okay? So you don't have to wait 10 days, 14 days, whatever, irrespective of the size of the embryo. If you have an empty sac, then it's slightly different, and perhaps not surprisingly, but you need to think about the sac size, which is logical. If you have an empty sac of less than 12 millimeters, then you need to repeat the scan in 14 days, so in 2 weeks. And that's different to what the college is doing and what the NICE guideline says, and this is based on our evidence. If the mean sac diameter is over 12 millimeters, then you can just repeat in a week. We actually just say 2 weeks for everyone, because it's just easier. Because why not? But I think that's an important thing. So 7 days for embryo with no heartbeat, at 2 weeks for small sacs, you might make it a week. I just find in our unit, to make it nice and clean cut, we just say 14 days, because it keeps it simple and doesn't complicate issues. But I think that data is important. And you can see that if you look at all these guidelines, what you see on the first scan, everybody agrees. If you look at the guidelines for everyone else, interestingly, the most useful was the Dubélé one. They got it probably more right by saying if you've got an empty sac, come back in 14 days. The NICE and the RCOG have not got it right, and that should be revisited. But the Dubélé, based on sort of expert opinion, they got it right better than anyone else. So I just think that's something to bear in mind. So the summary is that, as you can see, embryo no heart activity, scan 7 days later. Empty sac less than 12. If it hasn't doubled in 14 days, it's a miscarriage, but I would stick to 14 days. A couple of things. We now have 3D scanners. Be a bit careful. We do 3D scans and you see pregnancy like this. We've seen lots where people say this is an interstitial pregnancy when it's not. I know we're not supposed to say angular pregnancy, but in a 3D scanner you'll see these lateral pregnancies and they just sort of fill the cavity. They grow into the cavity. But it's not always that easy, and we do have to be careful. So if you have these nice things on machines, be careful, because we have no data showing the diagnostic performance of 3D scanning for interstitial pregnancy, for example, and there will be false positive test results, without doubt. Okay, so that was a viable pregnancy, so be careful there. This situation is problematic. When we were hearing earlier about the cesarean section rate, if you have a high section rate, it means you're going to have more scar pregnancies. And that's a problem in terms of knowing, which ones might go to term, which ones will have a pathological adherent placenta, and we don't have enough data. So is this a scar pregnancy? And you then, is it low implanted? Is it a scar pregnancy? Should you terminate the pregnancy? Well, it just depends. This is the Delphi, which Judith Hearn is doing the best work on this. But you have the sac now anterior to the cavity line, so it's a scar pregnancy. But the nice that it's 7 weeks, so it's a simple surgical procedure to deal with it. It's just an evacuation. But again, you can get this wrong. And I think there's quite a strong argument, I think, for having a centralized center that deals with things like scar pregnancies, both diagnostically and surgically, especially when they get later on. These early ones are not a big problem. The later ones, very complicated, and I think increasingly people are saying, well, you know, have one center that sorts these out, because it's not for someone who only sees one every 5 years. But I think now, you know, when you're talking about diagnosing miscarriage, it just depends where you see these pregnancies. You know, you just got to be careful and just allow sometimes time to pass by. You know, is that okay? That's not. That's clearly a problem. You know, and you need to be able to classify these pregnancies appropriately. A word about intracavity fluid.
Professor Tom,
Bizarrely, yeah.
just 3 minutes.
Yeah, I got you. Intracavity fluid, if you look at the NICE guidelines, says that having fluid in the cavity is a sign of possible ectopic pregnancy. And it absolutely isn't. All the data shows that it is almost 100% likely to be an intrauterine pregnancy. And this is, I mean, this is Peter's, we have data on this prospectively. It is a marker of intrauterine pregnancy and needs to come out of the guidelines. Why? Because in America, people see a pseudo-sac and they give methotrexate and they kill the pregnancy. I mean, this is good for me medical legally because I get sent these cases from America and that's very nice, but it'd be much better if they just didn't do it. And this is just another example. I just wanted to show an early pregnancy. People have these. Again, they look at this, they have color Doppler, and they think it's an AV anastomosis. It's not. It is enhanced myometrial vascularity in almost all cases, and it's almost always related to the presence of retained pregnancy tissue. If you remove the pregnancy tissue, or when it settles, this vascularity just goes away. It is extremely unusual to see an AV anastomosis. So this would come back in 14 days. I know I've only got a minute. So stick to the rules, basically. I know that it seems like a simple thing, but misdiagnosis is unacceptable. And you really need to think quite hard and make sure you're doing the right thing with these patients, being accurate with the scans, having them checked, bringing the patient back at an appropriate time, being aware of these situations where it can make the diagnosis a little bit more difficult. Don't worry if you have a scar ectopic or you think it is, to get someone else to look at it who's got more experience. In the same way as you'd send someone for cancer surgery, why try and take on a difficult late scar pregnancy if you've never done it before? Doesn't make sense. Finally, some of you will just use handheld machines in some environments or abdominal scanning. This is data again from Ahmed Sayasna, handheld machine, where he showed that measurements actually were very similar in early pregnancy when you're measuring a sac, but there is actually a difference. You tend to slightly under-measure, and so you just need to be careful. And I think if we're going to base miscarriage diagnosis on handheld machines, we are going to have to change these guidelines. So I would suggest that you're very careful and repeat scans. If you think it's a miscarriage on an abdominal scan, and you haven't got a vaginal probe, get someone who has got one to check the scan, or be very conservative in terms of bringing the patient back, certainly in 2 weeks' time. And I'm going to list this because I haven't got any time, but you can give people an indication of the risk of miscarriage, and I think that helps them when you bring them back to guide them. If you just say, come back in a couple of weeks, we'll see, that's not helpful. I think if you say, look, I have to bring you back, I'm sorry, I think it's likely to be a miscarriage, but we do have to look. Manage their expectations. The gap between reality and expectations equals trauma and anxiety. So if you can close that gap, manage people's expectations, they will do better. Can I have one final slide, Mr. Chairman? Very quickly, just to say, some people with IVF, I just want to make this point too, will say, oh look, I know it's 7 weeks by IVF, there's no heartbeat, it's got to be a miscarriage. But it's not, just to make this point. Here we have data from Sugar Murugezu, my fellow. Just look at the variation, 49 days after embryo transfer, and the range for the embryo size is that big, 4 to 13. Now you wouldn't think that, because you'd think, you know the embryo transfer date, it's got to all be the same size, but they're not. But these are for pregnancies that remain viable, they're not all going to miscarry. In other words, there's an implantation issue, and when implantation happens, when you put the embryo in. And that goes all the way back to Wilcox's papers. If you go back to Wilcox, he showed this. Similarly, if you look at gestation sacs, you have a similar situation, where you can see here at about 45, 46 days in blue, you've got viable pregnancies with a sac 18 millimeters, you've got viable pregnancies at 12 millimeters, same scenario. But over 47 days, If you've got an empty sac after IVF, it's always a miscarriage. So this data is multi-center data, but we need to validate this. And I think we'll be enable us to get away from a situation where someone comes for a nuchal scan and it's an empty sac and and it's awful to say, come back and have another scan, because often we do that. I think we'll be able to get away with not doing that when we get more data, which will be a very good thing. I'm going to finish there, but just remember this. Death of an early pregnancy, I can't say that strongly enough. Sometimes, I'm not saying it hasn't got the respect, but for a woman, it's the same. And you need to understand that and treat people accordingly. And sometimes, historically, that hasn't been the case. So I'll leave you with that. Thank you very much.
We have time for just one question. Dr. Ma.
Thank you very much. Can I just ask, in your unit, what's the protocol for a low implanted gestational sac? And if you're suspecting a scar ectopic, what's your protocol of management? Thank you.
Well, I mean, we normally, if it's, depends on the gestation to some extent. And, well, first of all, get it reviewed by someone senior. And we discuss it. We have an MDT. So we approach these in the same way with an oncology service. So we review them. Most of them, if they're very early, we'll bring them back in a week, often, as long as they're not very late. Why? Because often, as the pregnancy evolves, it becomes more clear where they are. There is a balance, however, because the longer in gestation you go on, the harder they are to treat. However, most times, we will watch and wait for about a week. And we use this, there's a Delphi, Judith Hearn uses, where we look at the intracavity line and the serosal line, and then based on that, we will designate what type of scar ectopic it is. In other words, type 1, type 2, whatever. If you have type 1, we will counsel the patient about continuing with the pregnancy with the risk of pathologically adherent placenta and the risks and some people will go for, will want to do that. I mean, if you're, if something happened to your first baby, you've had a cesarean, and this is your last option, they may continue with the pregnancy knowing the risk, it's a possibility. Most, however, will opt for termination. If it's more than that, we strongly say, look, the morbidity associated, particularly if it's going through the serosal layer, they will have surgery. But there is a balance, because I think if we don't have data, I think the earlier you are, the higher chance of misdiagnosis in some ways. But then the easier it is to treat. Because I think people used to get very worried about scar pregnancies. But in fact, surgery for a scar pregnancy at 7 or 8, 9 weeks is not really much different to a normal surgical management of miscarriage. In fact, all of us of a certain age, we hadn't heard of scar pregnancies when we were an SHO, right? And then every so often you go to theatre and there'd be blood on your boots. Why? Probably because some of these were scar pregnancies and we never knew about them. So anyway, I'm not sure if I've answered your question, but certainly we don't intervene straight away. We often wait a week if we're not clear, because the sac will change. Sometimes they sort of grows into the cavity, and sometimes it will appear to go into the scar, and then we're more clear about the diagnosis, and during that time we counsel the patient. Does that help? Yeah?
Yes.
Thank you.
Professor Bourne, sometimes you do scan at 7 or 8 weeks, you find bulge in the lower part of the uterus, and you scan the woman again after 7 days or a week, this bulge disappears, and then it comes back again at the next visit.
Are you talking about into the scar?
No, not
just generally.
Not the scar, in the anterior wall.
Yeah.
It's no previous scars. And when I looked into this issue before, they said there is some sort of contraction in the lower segment. Do you believe in this?
I'm not familiar with this, but I do believe that you obviously get uterine contractions, so I imagine that's possible. I think this whole issue of uterine function actually brings you on to another question.
It's functional because it comes and goes.
Yeah, well, if I can just take your question on a point, it's interesting what a caesarean scar does to the uterus in terms of its contractility, because the only other organ is the heart, which is a syncytial organ. And there's a lot of people now looking at how the myometrium contracts after a scar. So I know it's not quite your point, but I think it's interesting how the uterus contracts and reacts in terms of, and in fact, if you look at the waves of contraction in the uterus with someone with a scar, they often go backwards. And I think that's going to be an interesting area. But no, actually, I've not really seen what you're talking about, but I believe it may well be possible. I think it's just a question of who you scan.
Okay, thank you very much, and thanks for all the speakers. And we shall break now for coffee and come back in half an hour.